Right, good afternoon everybody. I'm Dr. Gary Howsam and I'm Vice Chair of External Affairs here at the RCGP. Now we've done several of these RCGP live webinars, but this is something a little bit different today as we're broadcasting live from the RCGP annual conference, which is also sharing the space with WONCA Europe annual conference here at Excel in London. It's lunchtime here and we're going to be discussing how to support refugees and asylum seekers, both as patients and as colleagues in the medical profession. I'm joined by a fantastic panel here today, as usual, both in person and virtually. And I'll ask them to introduce themselves as we go through proceedings. You can put your questions to our panel today by using the hashtag RCGP Live on social media, or if you're watching this on YouTube, please put any questions or comments below the stream, and we've got members of our team looking on there and we'll pass those questions through to me. We're on a super tight timeline today. We will have to finish at 25 past the hour. If you've not seen one of these sessions before, this is a way of those of us at the college being able to speak to you directly about issues that you tell us are important to you, and so that we can highlight work and activity that we're doing in those spaces. The video will be captioned and there'll be a full transcript that's made available after the live event, and people will obviously be able to catch up with this afterwards. Apologies to those in the room if I'm looking at you and it looks as if I'm looking through you. I've got reading glasses, so I can't even see you out there. It's very good for the iPad, but totally rubbish for anything else. In August 21, the Taliban executed a takeover of Kabul, and the BMA released a statement co-signed by the RCGP and other royal colleges and governing bodies condemning the invasion, and particularly the impact on female healthcare workers and medical students who are no longer able to practice or complete their degrees. Then in February this year, Russian forces invaded Ukraine, forcing over 1 million Ukrainians to flee to escape conflict, leaving lives, communities and families behind. While these recent events have brought displaced people into the spotlight, forced migration is not a new phenomenon, but recent years have seen an increased number of people forced to flee their homes and begin new lives right across the globe. In a quick Twitter poll we did, 91% of people feel they do not know enough about how to support refugee and asylum seeker patients. So today just shows how important this topic is to all of us in our day-to-day work. The BMA estimate that there's around 2,000 refugee doctors in the UK who are at different stages of their careers. Some that have had to leave behind 20 plus years of practice in their home countries and start over again in the UK. Targeted resettlement schemes have helped a small number of Ukrainian and Afghan healthcare professionals settle in the UK, but others arrive in the UK by many different routes, and this can also impact on what support or what roles are available to them. Today we'll be talking about some of the organisations that support displaced healthcare professionals and patients, and more information can be found on each of their websites as well. One of the important things to highlight here is that anything that we talk about today we'll make sure is in our resource centre so that you can link directly into that. So there's a lot to be getting on and talking about. That's probably enough from me. So I'm going to start with Stephen, who's joining us online. Hi, Stephen. We hear an awful lot around terms sort of migrant, refugee, asylum seeker, and that's sometimes used interchangeably. Again, on our Twitter poll, 67% of people felt they knew the difference between refugees and asylum seekers. But I was just wondering if you could just give us a sort of an update on what is the correct terminology to be using and the definition, so that we know what we're talking about and make sure we're using the right language. Thank you.
Certainly. I was asked to introduce myself. My name's Steve Nicholas. I'm a very retired GP who lives in London, and I've been volunteering with the Building Bridges programme in London, which supports refugee doctors through to their first jobs in the NHS. Basically, a migrant is anyone who, for any reason, moves from one place to another. And that would include people who move for study, for family reasons, for a job, or for economic reasons. And of course, most of them will move perfectly legally, but the ones in the headlines are the ones who move illegally. A refugee is someone who's been forced to move by the circumstances in their country of origin, whether by war or persecution, and they are entitled to humanitarian protection under the Refugee Convention. So if you manage to leave your country and arrive somewhere safe, you can then ask for asylum, and the government will make decisions to whether you're actually entitled to asylum. And while you're in that process of waiting for decisions to be made, you're an asylum seeker. And in the UK, you're usually housed by the Home Office and you receive £40 a week. The good news is that when your right to remain is recognised, you're obviously then safe and able to remain in the UK, but you also at the same time receive an eviction notice and all your money is stopped. So you've literally got 2 or 3 weeks to find somewhere to live and a new source of income. And the water is a bit muddy because both Ukrainians and Afghans recently have been coming in under different schemes which have different rules, and you end up with different entitlements. So I think my advice would always be, if you're dealing with a refugee or an asylum seeker, contact one of the refugee agencies to find out exactly what their rights and entitlements are.
Thank you, Stephen. So can I take from that, from what you're saying, that you're working with healthcare professionals that fall into many different categories?
No, we only work with refugees who have got indefinite leave to remain. And that's really because we've got limited resources and we're therefore working with people who are in a secure position to move on to the next step. Quite a lot of asylum seekers will actually be sent back. So we're not able to work with them, though obviously Refugee Council generally and other refugee agencies do work with them.
Okay, thank you. And you'd like to come in as well. If you'd like to introduce yourself, that'd be great.
Hi, I'm Lisa Harrod-Rothwell. I'm a GP and Deputy Chief Exec of London Wide Overseas, representing GPs across London, and Vice President of Doctors of the World UK, a charity aiming to empower people to access healthcare. Doctors of the World run a clinic in London for people who have been unable to access healthcare on the NHS. And I just want to highlight around undocumented migrants. So these are people who enter or stay in the UK without the documents that are required under immigration regulations. And I just want to highlight some of the reasons for this, because these people are entitled to primary care. It can be people who may be entitled to seek asylum but haven't because of lack of legal advice. They may be people who have been refused asylum, people whose visas are expired, and people have been victims of trafficking. There are lots of different categories of why somebody may turn up, for example, to a GP surgery with no documents. In the clinic, we frequently see people whose passports and documents have been taken away from them. And we also see people who have travelled having been tortured, who are being sought by people in their own country who have bounties on their heads. If you had a bounty on your head and had suffered months of torture and you had been freed, would you be carrying methods of ID on you? You wouldn't. So if people present to practice and they're undocumented, it is helpful to understand their circumstances. They are still able to access primary health care.
Okay, thank you, Lisa. That's really good clarification. Stephen, I wonder if I could come over to you again. I mentioned in the introduction that the people coming over, the healthcare workers, and let's focus on the healthcare professionals at the moment, have a whole host of level of experience when they enter the country. When they get here, do they describe a typical journey? Is there a typical journey? And what sort of support do these professionals need to get up and running again?
I'm just going to share a slide with you because it's quite a complicated... Sorry, something's gone wrong with my slide share. I'll just try once more.
Okay, thank you.
Sorry, I'm terribly sorry about this. So basically, the people that we work with, basically, when they come in, they have to go through the refugee and asylum process, which may take anything from a few months to several years. They're often people from the Middle East, also from some countries in Africa, but we get outliers from all sorts of other places around the world. Once they've got their leave to remain, they have to begin working on their English in order to get up to quite a high standard of English language in order to be able to register with the General Medical Council. So a lot of what we do is actually working with them, trying to help them through the occupational English test. And then once they've done that, they can apply to the GMC to start their PLAB 1 and PLAB 2 examination. And we give them a lot of financial and practical support with that. We run online classes, mainly doing role play and discussing cases. And then once they've passed their exams, the exam is basically, the first part is an MCQ and the second part are a series of OSCEs. We try to get them some experience within the NHS, either as a clinical observer or a new post, which has been very successful recently, called a medical support worker.
Stephen, can I interrupt you very quickly? We can't see your slide, so do you want to unshare so at least we can see your face? That'd be lovely.
Certainly, that's fine. Sorry about that.
No worries at all.
So once they've passed their exams, we try to get them into a clinical setting, either just a short time as an observer or a more substantial period in special protected posts where they get a lot of supervision and support. Because adjusting to a completely new health system and a completely new professional culture is something where people need a lot of help and support if they're to be able to do that safely and without a lot of stress to themselves.
Okay, thank you. And one of the things that's been mentioned is that a lot of these doctors coming over choose general practice as a speciality when they get there. Is there a reason why this appeals to them particularly? And what more can we do to welcome them in, particularly with the workforce crisis we're facing here in the UK?
Yes, I mean, a lot of them do, partly because some of them are working in primary care in their own countries, but also because it's very difficult to get back into the specialist ladder. If you, for example, been a neurosurgeon in Kabul, it's quite unlikely that you'll be able to get a neurosurgery job at St George's. So a lot of them opt for that. A lot of our refugee doctors are in their late 20s or 30s with families, and it's really good for them because the GP training is shorter to actually be able to settle into proper career posts.
Yeah, thank you. I think it's really important to remember that not only are they facing huge challenges in their professional lives, but also the upheaval in their personal lives as well, which will make any sort of retraining and moving back into a specialty really, really challenging. Just wanted to mention at this point, the RCGP has also launched a new international affiliate membership, which is open to people who have refugee status, a previous medical qualification, and who are looking to retrain in the UK. If that does apply to anybody that's either listening to this or catches up later, then details of that are on our website. Now I'm getting more and more...
Can I just very briefly say that there are similar schemes in Cardiff and Glasgow and Manchester and Lincoln and Teesside. But there are large areas of the UK where there are no schemes and there is no support for refugee doctors. Okay,
thank you. I'm getting more and more trust in the technology, and I'm now told we're hoping to watch a video from Professor Viktor Chichenko, who spoke at one of the plenaries the other day from Kiev on the impact of conflict on primary care in Ukraine. So I'm hoping one of the tech folk can make that so.
Access to medicines. In nearest to occupied territories, we had overwork and overloading because of those people who migrated to our town or more safety places. We provided medical care to everyone who needed, not only according to the list of our patients. We continue to hear exposures. We had rate warnings every 2 or 3 hours, even during the night. We proceeded all the time to shelters and provided care in unsanitary condition there, with absence of water, enough water and medicines, with only those things that we had in our doctor's bag. And after the 1.5 months of occupation, we received a lot of patients from post-occupied territories with decompensated status. And it is really a big problem for now to recover them and to direct them to the hospital. We still have some lack with medicines and lack of staff, although a lot of our personnel came back.
Okay, thank you, and thank you to Victoria for giving us that. And I think it's fair to say that we're all in awe of and humbled by the efforts of our colleagues working in family medicine and primary care in conflict zones all around the globe. I want to change tack a little bit now and introduce Emily and Victoria and focus a little bit more on the impacts on people coming over who are potential patients when they get to the UK. I want to start with some myth busting. We did another Twitter poll earlier on that said 74% of people said that primary care services can be accessed free of charge by everyone, irrespective of their immigration status, which means that 26% didn't say that. So let's come to our panel and get the answer. Emily, if you can introduce yourself and then answer the question.
Thanks, Gary. So I'm Emily Clark. I'm a GP based in Norwich. In our practice catchment area, we have dispersal accommodation for asylum seekers. So these are individuals who are supported to live in this accommodation. As Stephen said, they receive just under £40 a week just whilst they're in the asylum process. And I've got a keen interest in advocating for these groups, whether that's through individual patient care, but also through research and trying to ensure that their voices are heard through research. So in terms of the percentage of people still believing that primary care is not free, I'm reassured by the positive of the 74%, did you say? Really reassured by that, but I think that some of the confusion around that has been probably because of lots of policy changes, of things around charging and which groups are chargeable, etc. So it's not surprising that people taking the poll were perhaps slightly confused by what the regulations are. But I think it's becoming more known about that primary care is really should be free and accessible. And Doctors of the World that Lisa works for have done a wonderful campaign called the Safe Surgery Campaign, which hopefully she'll talk a bit about, which is just really saying that practices are not going to put barriers in the way of individuals registering for primary care, so that the administrative barriers such as demanding documentation, etc., are removed, and that these places are safe and welcoming for individuals, whatever their status, wherever they live, and hopefully primary care can be a safe space for all to come.
Thank you, Emily. The last thing we need is bureaucratic barriers, isn't it? And it's really important that we increase knowledge to make sure that isn't a barrier as well. Victoria, if I can come to you, if you can introduce yourself, please, and then maybe talk a little bit about the barriers to presenting and accessing services.
Thank you. I'm Victoria Georgie Brown. I'm a GP in Tower Hamlets in East London. I'm a researcher at Queen Mary University of London, and I co-chair the Health Inequalities Group of the Royal College of GPs. So, talking about barriers, there are lots of barriers. I'm going to focus on just four for this session. So the first one is actually the regulations around who is entitled to free treatment within the NHS and not just primary care are quite complicated. And they do vary, the rules vary depending on which country you come from as well. So I think quite a lot of asylum seekers and refugees are quite fearful actually of accessing health services because they are worried they may be charged. And it's very important that we move past it's very important that we absolutely reassure and myth bust the notion that they may be charged for accessing primary care services. Primary care services, general practice, are free for refugees and asylum seekers in all 4 nations. And actually, NHS England has created the NHS access cards that you can get hold of either online or from your local health watch service and distribute them at your practice to people so that we increase awareness on that. The other barrier, however, is that there are difficulties for people who don't speak English a lot of the time to get through the registration processes and also the processes of making an appointment with their GP. And I think moving to the remote ways of working probably has complicated this as well. There is quite a lot of variation in how different practices do these things, and I think we need to work closer towards standardizing these processes and making them a lot clearer in our website. And actually my team at Queen Mary University of London are working a little bit on a research project with NHS England to try to produce a little bit of guidance on how to do that. The third barrier is that we cannot assume that the first priority of this cohort of people is to access healthcare. There are all sorts of other concerns that they have. From getting access to benefits, to housing, to worrying about their families that they left at home, to feeling guilty about them making it and others that they care about couldn't make it. So as healthcare professionals, we need to be very mindful of this and deliver the consultation in a non-medicalized way. So let the patient lead the consultation. They may not be worried about their blood pressure, they may not be worried about their weight. Listen to them and prioritize their priorities and work with others as well within the extended team to establish trust. And I think trust is important not just for between people, between the patient and their healthcare professional, but also trust for the system, and that's something also we need to work on, because a lot of these patients and also other patients from vulnerable groups of patients are worried about their data and confidentiality. So that's another piece of work that we need to do to reassure them.
Brilliant, thank you, Victoria. Emily, I want to come back to you because it seems fairly obvious that these people are going to have sort of general widespread sort of health needs, but one can only imagine there's some fairly specific health needs that they have as well.
Yeah, absolutely. So it's they are patients first and foremost, and people who would have come with their concerns, like anyone would. But obviously there are particular communicable diseases that may be more prevalent. It's nice guidance now is to screen all newly arrived entrants from Afghanistan for TB, including children. There may be higher rates of HIV, hepatitis B, C, etc., depending on what their country of origin is. But the non-communicable diseases, long-term conditions, may be poorly controlled. They may have had huge gaps in their medication. The asylum process itself in the UK is pretty bad for people's health. So they often can get moved, even at short notice. They can be moved by the Home Office. So they then have a break in their medication. They can have then breaks in their general practice care, in secondary care, and have to establish a new relationship with a GP, start their story from scratch. And then the huge area is obviously mental health problems and mental distress. I'm happy to sort of talk a bit about that now if you wish.
Yeah, please.
Yeah, so obviously, as you would expect, mental health concerns are more likely in this group. But we have to be really careful not to medicalise kind of the distress that people can feel. So if you can imagine being an asylum seeker or refugee or an undocumented migrant living in poverty, having no choice in where you live, no choice in who you live with, no choice in what you're able to do with your time, not able to work, not able to volunteer, literally no way of kind of filling your time with meaningful activities, and losing that sense of self, then individuals can present hugely distressed. And this doesn't mean that they have a mental health problem. They are humans who are suffering because of what is being done to them and the situation they find themselves in. And I think as GPs we have to be careful not to over-medicalise that and over-diagnose conditions such as PTSD, and really work with what are their symptoms, what are their priorities, which bit is distressing them, and how can we support them, whether that's linking them with community organisations, whether it's providing them with a certificate so that they can get their free prescriptions, advocating for them, writing that letter to the Home Office, whatever it is, that's the bit we need to work with, rather than, you know, necessarily diagnosing them with a mental health condition.
Brilliant, thank you, Emily. And we talk about personalised care a lot, and I imagine this is a cohort of patients where that question, what matters to you, is probably more important than with any other group. And also not assuming we know about the baseline of treatment they'll have received back at their home country. So thank you. We're going to have to gallop forwards, I'm afraid, because time is working against us. So I just want to move us into a slightly different area. What can we do as GPs, as practices, and as a wider primary healthcare team to support these patients? And if I can just frame this, so Lisa, if I can come to you around making practices refugee-friendly and the safe practices work you're doing, and then I'll come to Emily and then to Victoria.
Absolutely, thank you. So whilst the rules around access to secondary care, as Victoria said, are immensely complicated, the rules to access around general practice are very simple. Everyone is entitled to general practice care. So why is it then that we hear those statistics of people being turned away because practices don't think they're eligible? Well, there's been a recent study that was commissioned by the Mayor of London, which isn't yet published, so this is hot off the press, which investigated this, actually looked at the barriers experienced by practices. Practices receive a lot of conflicting information, so they are told that they have to make sure the registration information is accurate, and documents enable that accuracy. And what's more, the form that has to be completed has lots of questions which, whilst not mandatory, relate to whether or not somebody is eligible for secondary care. On that form, it's not mandatory, but it's not clearly marked as optional. So it's unsurprising that practices are really confused over this. So what can we do? Well, as has been mentioned, Doctors of the World have a safe surgery campaign. It is a network of practices. Any practice can be a safe surgery. Any practice that is committed to overcoming the barriers to enable these people to be able to access general practice. Now, the four main barriers that people experience are not being able to provide proof of identity, address, immigration status, and fear of data sharing. So in order to help overcome these barriers, there are 7 steps that practices can take. 7 simple steps. Keep it simple. Don't insist on proof of identification. Don't insist on proof of address. Never ask to see a visa or proof of immigration status. Fourthly, do what you can to protect patient information. Now, the concerns around data sharing are founded. In 2017, there was an MOU between the Home Office and NHS Digital, which allowed information to be shared. That was overturned in 2018. Now it's the same as with everyone. You need a legal basis to share that data. For example, serious crime. Immigration issues are not serious crime. You can register somebody at an address such as a church, the practice, so if they are not comfortable giving you a home address. Fifthly, use an interpreter. And be careful if people are coming with an interpreter, because we do see lots of trafficking and people have lots of power over some of our patients. Display posters. And to reassure patients, you'll see online you can download posters in a plethora of different languages, which are all welcome here, explaining you don't need documents. And if you need a language that's on there, let Doctors of the World know, we'll see what we can do for you. And also empower frontline staff with training. Again, Doctors of the World, as part of the Safe Surgeries work, have a number of different training resources to help practices to be able to do that. So those are the 7 things, and it is really confusing for practices. I absolutely understand that. So just try and keep it simple.
Brilliant, thank you, Lisa, and it's really good to have such practical tips and advice, and we'll make sure that there's a link to those 7 things if people want to find it later. Emily, if I can come across to you, and I think we were going to talk about a recent article that's appeared.
Yeah, so recently, in light of the Afghan crisis, but also Ukrainian crisis, there's been some loads of articles that come out in the BJGP Life and the BMJ and the BJGP
around kind of really quick reads, 7 or 8 minute reads. They've got one of them here by Hannah Fox, who's in the audience, around the restrictive policies. Really quick to read, freely available online. And we'll put the links to them. But these are just really good ways for people to get a rough idea of what's going on, what the likely health needs are, top practical tips. And I guess my only practical tip would say coding is caring. If you code it on the medical record, it is there, it is flagged up as a vulnerability, whether it's coding that they're a victim of torture, FGM, they're homeless, in receipt of benefits, whatever it is, code it.
Thank you. And hearing coding is caring, I can feel Simon DeLucian's smile from somewhere within the building. Victoria, how, in terms of access to care, we've mentioned some of the barriers and some practical tips. Any more advice that you can give us?
Yes, actually I think the first interaction with these patients matters hugely. And not just refugees and asylum seekers, but also all people from vulnerable backgrounds. What we say to them when they first approach us can really either put them off from ever coming back again to access healthcare, or being the first step for them to engage with our health service and address their health needs. So what we need to say at that first interaction is that reassure them that we are here for them, that our services are free for them, and that we can help them. And I think that can make a huge difference. And finally, we talked about interpreters, we talked about changing our systems and improving all of these, but we know very well that probably one of the most important steps if we want to address health inequalities is actually having a universally available healthcare service which is free at the point of use. And therefore we need to fight for our NHS and general practice.
Brilliant, thank you, Victoria. So we've talked about what we can do as GPs and practices to help these people as patients. Stephen, I was wondering if we can come back to you again, please, and have another look at the displaced doctors. When they're going through their period of retraining or trying to get into the healthcare professions over here, what can we do as GPs, as primary care workers, as practices, to support our future colleagues to flourish in their new lives?
I think the first thing is to identify them. And then the second thing is to signpost them to local agencies and schemes that can help them. If you contact the Refugee Council, we will always talk to them and see what we can advise them about. Very definitely think about employing them as interpreters, as phlebotomists, as healthcare assistants, as note summarisers, or as medical support workers, because that gets them into the NHS at the bottom so they can begin to see how the system works. And then also think about specialist things like the Helen Bamber Foundation and Medical Justice, who help support asylum seekers medically in their appeals, and also make contact with your local refugee agencies and consider volunteering with them as advisors or trustees or simply as financial supporters.
Brilliant, thank you. And I think the other thing that strikes me is, although these folk are going through some really difficult times in their lives, it's really important that we thank them for what they bring to us as well, because they're going to enrich the NHS. They bring in experiences that are going to be so valuable for those of us who have the opportunity to work alongside them as well. And I think it's really important to frame it in that context as well. I think we can go to some questions from the floor now, he says, looking towards the team. So we've got a microphone. I told you I can't see. I'm going to have to peer over the top of my glasses like my dad does. There we go. So we've got the lady at the front here.
Hi, my name's Ngozi Anumba. I'm a TPD in the Yorkshire and Humber Sheffield scheme. It's just really a comment, really, to say that we in our scheme run it's a health access for refugees program, and actually for the last 4 years, we just need to really enthuse the next generation of GPs about this topic. That for the last 4 years we've run a simulated kind of, there's a refugee council come in and run a program that simulates a refugee journey, and it's the most impactful session that we run every year, and our trainees en masse then want to go and volunteer, and the safe surgeries, we get so much information out, and I don't know if this is kind of universally available across kind of other schemes, but it's probably my best session. It's the easiest one to put into the calendar as soon as I start setting out the training year.
Excellent. Well, it isn't available everywhere, then I think that's something we should aspire to, and we will shamelessly pinch that idea and come and find out more information so we can share that. Any other hands up? Anybody else would like to ask a question? Gentleman here, please, Evie.
Hi. In Bristol, we have actually the Haven, which is an organisation that is funded by the NHS and does an initial screening for sensible things for people who've just arrived off a boat or whatever. And that actually produces documentation, which then doesn't produce any problems to then registering the patient if they turn up because they've just been given a hostel or something like that in the patch. And I don't know whether that happens in other areas.
No, I'm seeing shakes of the head, but again, that looks like another bit of learning that we need to pick up on.
And just having that initial screening, just sort of so that you know that this person hasn't got TB, hasn't got HIV, all those sorts of things. Because otherwise, if you just see them for the first time, as you say, their health is not necessarily their first but where you can see someone who urgently actually needs Western medicine.
Brilliant, thank you. We've got time for... Oh, sorry, go on, Emily.
So coming back to that, the main issue is that primary care specialist services for this group are not, it's not... across the UK, it's not, it's not even. There's some patches where you have charities providing extra care, some patches where you have normal general practice, and some practices which will provide an enhanced service. But it's certainly not equitable across the UK, and that's something that should change.
Okay, I did say one more, but we'll have two more. This person here, and then the lady over there that just ran away from.
Thank you. Hi. Thank you. Really interesting. It was going back to the translation issue, to be honest, and I know there's some fantastic leaflets that have been really helpful on your website, which are brilliant. But I work in a small town in Sussex, and we are having very large numbers of Ukrainian refugees registering with us at the moment, most of whom speak little, if any, English at all. And when we've approached our services, our translation services, we've been told that there is one Ukrainian translator in the entire Sussex region. And beyond the obvious, which is lobbying the CCG and the services to address this, I just wonder whether you had any sort of thoughts, tips about this.
Yeah, well, I mean, telephone interpreting there should be good access to telephone interpreting. So yeah, lobbying the CCG because when it changes the ICS, lobbying them because that should be delivered. So, and actually giving the patients the choice of telephone or face-to-face, because if they're from the same small community, they may not want face-to-face interpreters because they fear confidentiality issues. So definitely they may prefer telephone. So giving them then the choice, but yeah, the telephone interpreting services should be commissioned locally for all practices.
Brilliant. Okay, we've got about a minute, so if we can have a 30-second question and a 30-second answer, that'd be fantastic. Thank you.
Fantastic session. Thank you so much. I just had just reflecting on how, as a trainee, I'd been told because it was taking so much time to provide continuity for a vulnerable trafficked lady in North London, that I sort of needed to draw a line somewhere and let it go. And I can't sort everything out in terms of housing or join meetings and so on. And I just wondered if it was something that needed to be done around supervisors being trained to support trainees to really address these issues and normalise that.
Yeah, go on, Lisa, you take that briefly, please.
The problem that we've got is that we have too many patients with a number of GPs, and we're all experiencing moral injury for the patients who have the greatest need, because we know that for many of our patients we're no longer able to offer safe care. We don't go home at night as GPs anymore knowing we've done a good job, do we? So I think this is really, really difficult. There does need to be education, we do need to understand, but hands on heart, we are operating within a context which is really, really difficult to offer everybody the care that they need. And I really hope that this does change over the next couple of years with government policy and NHS England policy too.
Okay, I'm afraid that as ever with these sessions we've run out of time, so I'd like to say thank you to everybody who's come along today, and for those that are watching online. It will be available immediately afterwards on YouTube. Our next RCGP live conversation will be something completely different, looking at the Fuller report and the integrated care systems and potential changes and opportunities that will bring. Stephen, Victoria, Emily, Lisa, and especially the tech team that have made this happen, thank you very much. It's been a great session. Thank you very much.